Yeah, you're good, Cara.
Perfect. Bum, bum, bum. Right. Can you see my screen?
Yes.
Fab. Okay, so this case, another shout out to one of my lovely student midwives who helped me with this one as well. It's always great to have extra people to give me a hand with these things. So this lady is a gravida 1 paranaut. She has a medical history, BMI of 31. She has a beta thalassemia trait with possible coexisting alpha thalassemia and or iron deficiency. This was an IVF pregnancy due to same-sex relationship. She had a high chance combined result from her T21 screening at her initial ultrasound, but a NIPT was sent and low chance result. 20 weeks, she had a normal scan. 25 weeks, she had one episode of reduced fetal movements. She had follow-up scans at 31 and 35 weeks, both all normal. Baby on the 57th centile at 35 weeks with normal fluid and normal Dopplers, and growth was sort of plotting in the right direction. Induction of labour was booked for the 19th due to maternal age and her IVF, which would have made her 40 weeks. So she actually
Sorry, Cara,
arrived.
how old is she? It's not in the notes.
Sorry, she's I think she's 43.
Okay, thanks.
Tell me if I'm wrong, but I'm pretty sure anybody that we have that's over 40, we recommend induction from 40 weeks.
Yeah, that's correct.
Perfect. Fabulous. So yeah, there's your history. She was booked for an induction on the 19th. Apologies, I should have taken the date out of there. But she actually shrom beforehand. So she came in 2 days prior, so she was 39 and 5. And she'd shrom, unfortunately, meconium stained Lycor at 1400 and then was admitted to triage 2.5 hours later. And this is her initial CTG. Observations, as you can see, completely normal. Blood pressure of 109/74, pulse of 93, resps of 18, SATs of 98%, and temperature of 36.4. This is her initial triage assessment. So baseline sat at around 130, 135. We've got accelerations present, and she's definitely contracting as well, which is good. But yeah, and then this CTG continues. And then at 17:15, she was examined and found to be 1 centimetre dilated and posterior. So general plan of care due to meconium is to bring her to labour ward and obviously see how she progresses, possible use of Synto. Any concerns with this CTG at all?
No concerns. The baseline is fit for gestational age, and she's contracting spontaneously regularly, and accelerations with good variability.
Perfect. And she's, yeah, I think it's fantastic as well that she's contracting, considering it. I don't think she'd been contracting for very long before she came into triage either. So hopefully that's a good sign that she'll make quite good progress in labour as well. This actually continues for a wee while longer, and she's now on labour ward. At 18:05, she goes out to the toilet and she's just requesting a 15-minute break from the CTG, which was granted by the obstetric team at the time due to the fact that there was no concerns before we essentially made a follow-up plan. Still contracting sort of 3 and 10, and our accelerations here are obviously really reassuring signs. Normal variability and baseline remains stable, which is great. So she has her break. And then she comes back on. The CTG is recommenced. She then has an epidural due to the fact that the obstetric plan now was for Synto infusion just to sort of help her progress in labour, and she decided to have her epidural prior to this. So epidural was commenced and test dose was given at 18:43. Sorry, epidural was started at 18:43. I think her test dose was given at around 18:55. Worked quite well initially. So Synto was then started at 7 p.m. Lots of observations up there, as you can see, but all sort of within normal ranges. No concerns with mum or fetal well-being at this point. So we continue. Again, baseline remains nice and stable. I think that the CTG dropped down to maternal pulse here, although it's not sort of written as to why there was this loss of contact, and it could be a deceleration, but otherwise completely reassuring factors and sort of nothing concerning when it comes to those decels, if it is a decel. Again, observations all completely normal. So the plan was just to continue, and then Synto was titrated as per our sort of half an hour dose up kind of protocol. So increased to 6 mils an hour at 8 p.m. So this is now handover time. Again, a little bit of loss of contact there, but nothing that we're majorly concerned about. And even if this was a decel, it's sort of variable and recovers back to baseline nicely. So all reassuring signs, and so are her obs. Moving on, Synto is now up to 12 mils an hour, and that was at 2045. At 2100, obs still remain completely normal. Any concerns, anyone?
Anybody to answer, please, because Kara is waiting. I'm in the car, so I wish I can see the screen. So yeah.
It's fine. It looks like we're sort of variability is slightly more reduced towards the last sort of 20 minutes of this CTG, but you know, this is also reassuring. Could be cycling. The fact that this baby has had episodes of sort of good variability, acceleration still present. We could just be going through a cycling sleep cycle, so nothing majorly concerning here. Synto was maintained at 12 mils an hour due to the fact that I think the midwife at the time was a little bit concerned about the reduced variability, although otherwise sort of completely normal. Acceleration is still present. I always notice these, and I don't know whether I'm being dramatic, and I probably am, but it always kind of confuses me a little bit. We get sometimes these tiny decels which don't even count, and it's one of those things where you get a magnifying glass out, and we always sort of say, if you need to get a magnifying glass out to assess a CTG, then it's almost certainly not what you're thinking. But I'm always very aware of these little decels that we get, that looks like there's shoulders either side of them, or what looks like accelerations, but they aren't. So there's one sort of, you can see at 2152 and one at sort of 2213 or whatever, that just sort of happen to coincide with the contractions. I know that they're not concerning, but it's just something that I always end up looking way too much into, I think, sometimes when my brain gets a bit paranoid. But otherwise, completely normal CTG. She's contracting really well as well, so we're getting up to sort of 4 in 10 now, so hopefully she's making progress here and still comfortable with her epidural, and obs are still all completely normal.
I wouldn't worry too much, Kara, about this shallows, except if in the context of chronic hypoxia where there is no variability as well, but in any other context, no.
Yeah, absolutely. I think I don't know if my brain is just kind of tuned into these tiny little insignificant things, because I'm so used to them being so insignificant, and then all of a sudden it turns a bit dramatic, that they don't cause me paranoia, but it's just something that I always overthink sometimes. And there's a couple more of them on this slide, but absolutely not concerning. This is still a completely normal CTG. This midwife has also very well documented that on palpation she was having resting tone in between the contractions, something that I say on pretty much every single week. So you're probably all for those of you that come weekly, very sick of me saying this, but I cannot stress the importance of making sure that we're palpating the uterus for a minimum of 10 minutes whenever you're taking over the care of a woman, and abdominal palpation as well, because it's so important to make sure that your resting tone is there. We always say as well, it's not just about how many contractions she's having, but it's also about how much time she's having her uterus is resting in between. So just as a sort of side note, please, everybody, make sure that you are doing that really frequently, or as much as you possibly can anyway. She's moved position due to the fact that this midwife, I think, was just slightly more aware of the fact that there was these little loss of contact episodes were more decelerations as opposed to dropping down to maternal pulse. Absolutely nothing wrong with that. Obviously, we want to make sure that we're getting a good fetal heart rate. So she's moved to left lateral, I believe, at this point. And maternal pulse is also palpated during that slight decel that you can see at 2203 is another really good indicator. We almost forget to use our hands sometimes because we have so much technology now that really helps with our assessment. But yeah, again, just manually doing these things is so important. So just as those sort of key messages to come off of this as well. Next slide. So we've got a few more variables here, but non-concerning, less than 50%, but also very much back to baseline with normal variability in between. She was moved to left lateral then, but beforehand I think she was sat upright. Observation still completely normal, and pulse normal too. And she's still contracting sort of 3 to 4 in 10 here as well. So she's now moved to right lateral. Again, observation, sorry, I'm repeating myself. Observation still normal. CTG baseline still remains stable with good variability, slightly maybe a little bit less than beforehand, but again, cycling, no major concerns here. And then I believe the registrar just came and did a quick review of this lady at around 2340. But yeah, always happy. So we're now on the 15th of the month. Again, this is past midnight now, so she's been an inpatient with us since about 4:30 p.m. Sorry, 6:30 p.m. No one sort of VE'd her again, but routinely we wouldn't do that until 6 hours post-synto, which I think is coming up very soon. Some loss of contact at the end, but moving position to try and obtain that, which is really good. And obs still normal. Observations still remain normal, and at 0100 this lady's made fantastic progress. She's examined, she's found to be fully dilated, the presenting parts at spines, and just due to that loss of contact at the beginning, an FSC was applied. We always kind of have this debate, I think, as to whether or not to use FSCs. I think some people are very keen on them and some people maybe aren't. It's very much sort of practitioner dependent. But yeah, if you ever are experiencing lots of loss of contact, I think we need to encourage the use of FSCs more, because they do really improve being able to interpret our CTG. But yeah, any concerns, any questions at all?
No concerns.
Perfect, thanks, Maya. So any changes to our concerns?
She's now starting to have some decelerations. I'm not convinced about, I mean, the decelerations before did not worry me at all. But the baby is still spending adequate amount on the baseline. They do have some chemo components. So at this stage, I might just reduce the center a little bit, but she has got, did you say she's fully dilated at spines?
Yeah.
I mean, it's from the progress, I'm assuming she's away. Otherwise,
yes.
For a primip, she did not progress that quickly. The only alternation I might do at this stage is just reducing the center a little bit, just so I can achieve 1 hour of passive descent.
Yeah, so she was fully at 1 o'clock in the morning, and at the very end of this CTG it's 2. So this would have been this trace specifically would have been her hour. But yeah, there wasn't any changes made
I would
to the.
still reduce it a little bit. I would still reduce it because I still probably have an hour of pushing. She's primate.
Yeah. Also note the difference between these two. So our original baseline's always been like 130, 135, and at the end of this CTG it does go up a little bit. And note the fact that we're now sort of sat in between sort of 140 and 150, more 150 in the majority of the time. The thing that sort of interested me about this is the fact that it looks like we're bordering here on, if you look at the amount of time the baby spends at baseline in comparison to the amount of time it spends decelerating, we actually are bordering here on a subacute hypoxia, because the baby, if we're now considering the baseline to be around 150, we're spending 1, 2, 3, 4 out of that entire 25 to 30 minutes, we're not spending very much time at the baseline at all.
It is 50% on baseline,
Do you
relatively
think?
speaking. I would only reduce this into a little bit and just see what it does.
I think the recovery with the deceleration, it seemed to take, they're quite wide.
Yeah, they are chemo. Yeah, they are. But this is why I would reduce it, assuming. So from what she described, it sounds like it's a delivery in the room if I need to intervene myself. But obviously I want her to do it herself, and this is why I want to maximize her chances. So give her and the baby a little bit of rest and see how she progresses.
Yeah, absolutely.
There's no urgency. That's the thing. What's the urgency? She's fully dilated at the spine. The worst case scenario, you do a QE or a lift out, and then, you know, she's sorted. But then let her do it herself. So rest the baby a little bit so that you don't have to do it as emergency.
Yeah, absolutely.
She's had an hour of descent already, Cara, hasn't she?
Yeah. So at the end of this segment that you're looking at, that would have been an hour, exactly an hour.
Mind you, also with epidural primate, sometimes we give them 2 hours. So yeah, she's primate. You just want no rush. So just rest this baby a little bit and then let her do her thing.
So it's just worth noting with this case, this lady was in a room where I think the central monitoring wasn't working particularly effectively, because we've had issues with cables and all sorts. But yeah, this wasn't observed. I think this was only observed by the case midwife at the time. I totally agree. I think maybe reducing the Synto slightly would have just helped to sort of give the baby a bit of rest.
Because I think in half an hour you're deeming the registrar for instrumental. That's what I'm thinking. So now the baby is still coping okay, but in half an hour the baby will be tired, and then you're deeming yourself for instrumental, while just giving the baby a little bit more chance to recover, flush all of the you know, the lactic acid that's now developing in the baby, will just give the baby enough time for mom to start pushing, and then the real stress will happen. So just give the baby, even if you're going to start the second stage in 10 minutes, there's no harm in reducing Synto. Remember, this lady has started her labor spontaneously. So we only needed to give her this extra push with Synto. So if she started spontaneously, we're not inducing her with Synto. So in some units, they would stop it altogether.
Really?
Yeah. What she started spontaneously and she progressed and she's OA. In Kingston, this is what we used to do. Like if she started spontaneously, you needed to give her a kickstart, you know, and she's achieving that. And the baby's now a little bit starting to show some signs of distress. She's at second stage, you know, reduce it. What's the harm?
Yeah, I am familiar with that as well, but usually for multiples, not necessarily primates, but yeah, you're absolutely right.
But it's not induction.
But at the beginning, Maya, she was contracting too. So if we stop it completely, she might go back
No,
to
I'm not
just.
saying stop it completely, but now she is an established labor and she progressed very, very well. So why are you, if you now started to see signs of fetal distress, the baby's telling you, I'm a little bit under pressure. You've got an hour, you can deliver this baby. So you want to maximize her own chance of having a spontaneous normal vaginal birth. So I will want to support her doing that. I don't want to add extra stress so that I deem myself for instrumental. If we keep on going this way, I'm 100% guarantee you, I'm going to deem myself for a instrumental in the room.
Yeah.
Yeah.
Okay. Would you check to see if the head has come down? Would you do like a quick V if the head is just literally just sitting there now?
I don't mind in this one because she had only like 2 VEs. So I'm not increasing her risk of infection, especially that I want this baby to be delivered ultimately by the end of the hour. So yes, I don't mind a baseline to see where I am. If I'm the registrar looking at this, I will want only also to confirm to myself that in case of emergency, I can deliver in the room.
That makes total sense.
Just to add a couple of points here, Cara, please.
Yeah.
Number one, the couple were offered in the beginning the option of cento versus the option of cesarean versus the option of wait and see, which like if she's contracting on her own. So the middle option of cento was chosen and the agreement was like this. The second thing about the 6 hours post starting cento is slightly unfounded. So you would say if there is regular contraction, you would examine 4 hours as usual. You wouldn't wait the 6 hours just because you are starting cento on a 1 centimeter. So these are two small fundamentals that we need to be acknowledging that NICE guideline has put, and when I was filling as a requirement to the NHS England, there is a tick box amongst about 150 tick boxes that we are offering the options of induction versus cesarean versus expectant to all ladies. We cannot just go and say start cento. We cannot go and say cesarean. We need to involve the woman and again with the rationale of Montgomery discuss pros and cons. Next is the cento. If she is regularly contracting and we are putting the cento on, we examine 4 hours after regular contraction. So the 6 hours is just a very rough number that has no meaning except you are virtually imagining that she will take 2 hours till she starts regular contraction, which is sometimes not right. The third thing is, as Maya said, reduction of the cento at this point of time is absolutely right. Even if you reduce it completely to the 3 to 6 to something very small, to allow descent is okay because we reached the full dilatation. We don't want to stress the baby. And we don't want to do a hasty instrumental that can lead to a third degree tear. Because also, if this CTG continues like this, you will have a prolonged deceleration of 3 minutes, 6 minutes, whatever. You will have the emergency buzzer. You will have people coming in. You will have a forceps. Let's say the forceps is doing its job and delivering the baby in good condition, everything. There is also a second piece in the equation, which is the perineum of the woman, that she will live with this perineum for the rest of her life. So there is no need to just and like do things in a hurry, and try to play the game with the baby as well. Reduce the cento, relax the baby, and then when the hour comes and you are starting to push, You can slightly increase the Cento again with a very limited amount. Even you can half dose it, and then you have the option of the instrument. Thank you.
Perfect. Thank you. So this continues. At 02:15, so about an hour after the CTG starts to become much more suspicious, the midwife in charge is informed of a pathological trace. Does this change our plan of care at all? Does anybody want to add anything?
So the baseline has gone now to 170. The variability is reduced. The D cells are getting wider. We haven't reduced the Cento. And we're pushing. Are we pushing?
I think she starts pushing at around 2.
So, Cara, this baby now starting to throw some catecholamines to compensate. So the baby starting to show compensation, which means the baby now starting to rise the baseline because we stressed the baby before. So it's still not too late. Remember, we still have 1 hour. There is no rush. Rest the baby, and then, once you're back to baseline, the baby is starting to flush all of those lactic acid, then we can start pushing again. So the baby is telling you exactly what we said in the previous slide. Don't stress me. And you're not in a rush. You are fully dilated. You are at spines. Rest him and let her do her thing.
Would you go pushing every other contraction, Maya?
Well, I wouldn't start even pushing now.
No, when you do start.
Well, once the baby is rested a little bit, I just want to rest him. Once you rest him, remember, this baby is in a marathon. The baby is running. So you're going to add the stress. Why would I want to add the stress to this baby who was beautifully, the only reason why we deemed her for induction initially was because of maternal age. The baby didn't show signs of chronic hypoxia, didn't show placental insufficiency. So this is a normal, fully grown baby with a normal growth chart. So I'm assuming the reserve of the baby is perfect. So this is all what we're saying is because of what we introduced to this baby. So I still have the luxury of waiting for a little bit, resting the baby, and then putting him through the stress of second stage. There's no rush. There's no choreo. So, I still have at least half an hour. I can rest the baby, even stop Cento at this stage, rest him, and then work with Cento if you are not having contractions, and let her push.
Okay.
So, but then later on, once you've rested the baby, you can start with pushing for Indrani, every contraction, if we're back to baseline and the baby is recovered and all of that. If I'm not happy, then yes, we can consider, but I would definitely not add stress to, to harm to stress. Like I wouldn't now start pushing whatsoever. I would just stop Cento at this stage.
Yeah.
I don't know if anyone has got a different view. I think there are more registrars on board.
I agree with you, Maya, but there is one thing. We didn't induce her. She came with strong MEC.
Oh yeah, I forgot the MEC bit. But still, I would relax the baby. Remember,
No,
she
I don't.
progressed. She progressed very well first stage. Yeah.
Yeah. No, I don't disagree. I'm just recapping that.
I'm just thinking, like, if now I'm not happy, what else? So I'm stuck now with two options. Either I instrument her now, yeah, or I rest him and the baby, and then see what response. Because remember, we've not rested this baby. We've not done that experiment on the baby yet. We kept on going.
This is very true. And the Cento is still at 12, I believe.
Yeah. So we don't know how the baby is going to respond. Just give the little baby a breather and then see what he responds. If he's still not recovering, then yes, go ahead and get the baby out. But if the baby is recovering back to baseline, you didn't lose anything and you didn't add much time. I'm talking about 20 minutes, not hours.
Perfect. What gets a little bit hectic next? So midwife in charge is escalated at 0215. Can I just ask, does anybody agree or disagree with pathological trace under FIGO?
I think this baby's trying to compensate so far. So the baseline rise is the baby's response to the stress. So what I'm reading is catecholamine in the blood. That's what I'm reading now.
Yeah.
Maybe it will start decompensating towards the end.
Cool. So midwife in charge comes in within 3 minutes, and the registrar makes a quick follow-up, and the decision is made for a forceps delivery. Just as a side note, guys, this whole writing all over the trace is just, you know, I say this multiple times as well. I fully appreciate that we need to write stuff down somewhere, but do we have to do it in the middle of the where we interpret the CTG? Pediatricians are present in the room within sort of 4 minutes. Forceps are popped on at 2:31. Episiotomy is given, and baby was delivered with 1 pull. So 0233 delivery of live male infant. Agree with the decision?
I'm not going to comment.
Who's
I
that?
would say, you know, this was Maya.
That was Maya, yeah, because I would have rested before that prolonged decel, which Nagib predicted 30 minutes earlier.
Mm-hmm.
So Kara, I agree and disagree. So first, I will disagree because if the head is high, so I will say the 2 scenarios here that I was involved in, not in this case, of course. One case, I come similar episode of I come on the shift actually, so I have no clue what's happening. The emergency buzzer is there. I rush to the room, head at spines. The deceleration is for nearly 9 minutes. I put the forceps on, I deliver, baby is fine, but 3C tear and PPH and so on. The second one is same scenario, but the head is at +2. So what decides right or wrong in the decision is not an absolute CTG interpretation. Again, CTG, we need to emphasize, CTG is only one small piece of 100 or 1,000 pieces of the puzzle that we need to put together. The CTG plus a VE plus the meconium plus the age of the woman plus big baby, small baby, plus pelvis, plus perineum, plus FGM, put whatever you like. So in this situation, if the head is high, I would have given terbutaline and waited and delivered at ease. Of course, if I would have acted as Maya said earlier and reduced Cinto, I wouldn't have reached this situation. If I am +2, I would put the instrument on and deliver. And it seems here the head was low and delivery was fine. Again, I don't want to comment on forceps versus Ventouse because again, it's not my evidence. It is the evidence of the Oasis and Miss Tucker. And that Ventouse is more of a like helpful to the woman so she doesn't develop lateral wall tear, 3rd-degree tears, and so on. Forceps has a higher rate of 3rd-degree tear. Hopefully, yes, this one didn't have it. But what I want to say is Ventouse is the key, is the instrument of choice if the head is low rather than forceps. I know that there is some people who prefer forceps, but so you can't generalize it, Kara, and say is it the right decision or wrong because it has many elements in it.
Oh, 100%. This is why I love these case reviews, because it's good to hear. So, you know, the whole purpose of the case reviews is to review the case, not just review the CTG. So there's so many additional elements, and I think we do kind of fixate sometimes on one part of the story, whereas looking at the complete overall clinical picture is actually essential. Which is why it's always great when we have multiple different opinions, or not even different opinions, but multiple people just like adding the additional factors into this. And like you say, Mr. Nagib, you know, when you're looking at a CTG, sometimes you're not anticipating, okay, what am I thinking about in terms of how to deliver her for her perineum? That kind of becomes like a past tense thought, as opposed to something that's, you know,
you are right.
happening right now.
I want to share with you a recent case, actually, a similar CTG, not in the last year or 2 or 3. So nobody really gets thinking whose case is this. But similar CTG, registrar went and delivered, BMI of 52, well done delivery, baby is out fine, buttonhole delivery, buttonhole tear on the rectum. He/she repairs, calls the consultant. Consultant says, "You are senior enough, carry on." The tear was done. She has a rectovaginal fistula.
Gosh.
Rectovaginal fistula ended up by being referred to the colorectal. Colorectal did a defunctioning colostomy. Colostomy was done. They tried to reverse it. She's BMI of 55 or 54, something like that. They couldn't reverse it. And the last thing I heard, that she's in ITU in the last few weeks, battling for her life. She might die from sepsis.
Oh my
So
gosh.
yeah. So that is the spectrum that I want to say. Yes, deliver the baby if needed with the best instrument to like deliver the baby, and make sure that the mother has a life after. She is 20, 30, 40, whatever she is, even if she is 50, she has a perineum. She needs to open bowels. She needs to pass urine. She needs to have sex. She needs other things in life other than having the baby. Yes, medical legally, the HIE and everything is one of the most important things. And I don't disagree. And I'm not saying stop doing a Cat 1 section, stop doing a Cat 1 delivery of instrumental. But what I'm saying is put everything in context. Don't let the adrenaline rush that Maya is talking about, which is happening in the baby, also rush in your brain as an obstetrician and as a midwife, and jump on the lady and deliver knowingly and unknowingly, when you can sometimes do some curative measures. Every single instrumental was reviewed in St. George's when I was there, because there was stan. And when you have done an instrumental, when there was no stan event, there was some question marks, I must admit. And why did you do harmful intervention? I don't want to go, as the Labour would lead, into this kind of high criticism of why you did the instrumental, but I want to say instrumental with thinking, with preemptive measures to remedy the situation, and with the best instrument possible, and with the perineal protection, and with some sort of calming down on yourself. I know it is difficult. I have been in this situation. I just said I caused the 3C tear because of my rush, and because I didn't rationalize that I need to give terbutaline. But that learning from mistakes, learning of how I fell into traps makes the situation better. So yeah.
Perfect. Would anybody like to guess the APGARs or the gases of this baby?
8, 9, 10, or 9, 9, 10, and 7.25.
Anybody else?
Yeah, I think it's the same, but I think the lactate might be a bit raised.
Okay, perfect. This baby was born with APGARs of 9, 9, 10, venous pH of 7.30, base excess of -5.9, and a lactate of 3.6. So slightly raised, but not drastic. Baby was absolutely fine for the first sort of few minutes of life-delayed cord clamping. Baby was taken to resuscitate at 2 minutes. Needed some meconium in the mouth suction because it was just completely prominent, although didn't require any respiratory support. But there was increased work of breathing noted at 10 minutes with some subcostal recessions and nasal flaring. And then at 45 minutes, baby was still on 45% oxygen with increased work of breathing. So unfortunately needed to be admitted to the unit with plus or minus intubation, just for sort of positive airflow, essentially. I believe the baby is now out of the unit and is doing absolutely fine and is doing really, really well. But yeah, any questions?
The question that I want to ask the congregation with us is what you, Cara, asked in the Attain meeting. Is it avoidable or unavoidable? And I want people to have a consensus here.
Can I start?
Yeah.
I do think it was avoidable, to be very honest, because we predicted this is what will happen later on. The baby, you know, I'm not saying we could have avoided the instrumental, because maybe later on it would have deemed, you know, necessary, but we didn't give any chance for this baby to prove or recover or anything. So we can't, in the absence of not having done that, we can't really say yes, it was unavoidable, because we could have tried the first option, rested the baby a little bit, improved the CTG, you know, lowered the head so that we can have. I mean, this is the result. The fact that the baby had meconium aspiration and ended up in the unit is just because of the meconium, which I initially missed. But we could have delayed things a little bit and probably ended up with not having a forceps delivery. You could have pushed the baby out.
So my question to you, Maya, respecting your opinion, of course, when you say avoidable, can you say, hand on heart, avoidable when a meconium was present from 1 centimeter, that meconium aspiration happened because we didn't rest the baby?
No, it could have happened from the meconium aspiration could have happened from 1 centimeter.
Exactly.
So that
exactly.
is, I mean, avoidable admission to unit. That's not my. I mean, would I have done things different? Yes. Could I have
No,
avoided the baby being admitted to the unit? No, probably not. The meconium aspiration could have happened from before she started.
Exactly. It's the question that Attain meeting, or the meeting that Cara is leading on. What is the abbreviation of Attain again, Cara?
So it's avoiding term admissions to neonatal unit essentially. So we report.
Exactly.
I do a report on every case that's requires admission.
Understood.
Exactly.
No,
Exactly.
I think that is not avoidable. But obviously,
Yes.
the baby's gases, and I've told you that we didn't have a hypoxic stress that we needed to do the forceps. So I think the forceps
Exactly.
was avoidable, but the meconium aspiration was not. So this is what
Exactly.
I meant by my comment.
This
And
is
now-
exactly
and-
what Mr. Naguib said.
Yeah, because Maya, when I was in the meeting, I said, listen, the management can be altered, yes, but the meconium aspiration could not have been avoided because we don't know at what step, especially that, as you rightly said, Maya, that there is no hypoxia on the gases.
Yeah,
So if-
there was no hypoxia. Like if you had stand, probably it wouldn't have picked up this even.
Yeah.
But
So
I don't think there was a hypoxic stress significant enough for intervention.
exactly.
We could have done a measures, resting measures to kind of improve delivery or second stage. But the meconium aspiration, no, you couldn't have avoided that. How would you know that you could have avoided that?
That's
Absolutely not.
exactly. That is exactly. The Attain is asking, would it have been avoidable?
No, the answer is no.
Admitting her
That is
to
not.
SCABU, or admitting the baby to SCABU, and we said no.
No, that's not avoidable. Was this discussed, this case?
Cara brings all the admission to SCABU to the Attain meeting from the pediatrics point, because some of them are hypothermia. So the peds comment as, for example, this is avoidable or something. And we comment on the obstetric part. Was it avoidable? So we said no, the meconium was present since 1 centimeter, and it is not hypoxic event that caused the aspiration, which means that aspiration could have happened in the last 7-8 hours, which means I could not have avoided the admission.
I agree, if this is what it means. Yes, I agree.
Perfect. Would anybody else like to add anything at all?
I think, Cara, additionally, this lady had a PPH, if I remember rightly.
She did, yeah. She had
1.2. I feel more. I
there?
feel
2 point something, if I'm thinking of the same lady.
It
And
was,
yeah,
she
one
had
point,
a pack as well, because she was
and
kind
the
of
pack.
Yeah, she had a pack.
Exactly. Thank you. So now, if we put the PPH also on the equation that we mentioned to add another piece on the puzzle, this piece is with the hyper stimulation or the increase of Synto that is causing the deceleration to the baby, has caused also the uterus not to contract well. The forceps has caused a little bit of a trauma. Again, I'm not saying whoever did this was wrong. Absolutely well done to the person who was on. But what I'm saying is always there is a fine adjustment, fine tweaking to reach a better management. And we all learn. And maybe if I am on the night at 2 o'clock in the morning, I would have done the same. Our physiology as obstetrician, as midwives, don't work similarly on a night shift like in a day shift, and at 5 o'clock definitely different from 10 p.m. So what I'm saying is fantastic, well done. Baby is fine, mother is fine, but what I want to say is a fine adjustment of the management. Thank you so much, Cara. It is absolutely lovely discussion and lovely case. Thank you so much.
Thanks, everybody.
Yes, thank you, Cara. Thank you, everyone.
Thank you, Cara.
Thank you. No
Bye.
worries. Oh, I'm not going to be here next week because I'm on annual leave. I think